അല്ലല്ല, അത് സോഫ്റ്റ്വെയർ വഴിയാണ് വർക്കാവുന്നത്.
മറ്റേ പോയിന്റ് Good morning, everyone. Respected Chair, delegates, thank you all for welcoming me here for this annual conference of your Physical Medicine Department. Now, I'll be talking on shoulder imaging anatomy and a few relevant pathologies. Now, shoulder is not like any other joint. It's slightly a complex joint with a lot of soft tissues around. And imaging modality will be always focused on the basic 4 imaging modalities like the X-rays, ultrasound, CT, and the MRI. Now, since there is a lot of soft tissue and the planes are not in the true axial coronal or sciatic, MRI of course has got an edge in shoulder imaging. But to put it in a more simpler way, an approach for imaging of the shoulder, we'll go by a step-by-step approach with an X-ray, ultrasound, CT, and MR. Now, in that way, if you take, I'll have to pick up from this limited time. I have to pick up any one group of pathologies. I'll be focusing on trauma because more than that, that's the most number of cases we get. But of course, all the arthritic and the neoplastic processes also will have a similar approach as far as the imaging is concerned. Now we'll go to the next slide. Now, basically, as far as imaging is concerned, the major joint is the ball and socket joint. That's the glenoid and humeroglenoid joint. Along with that, the other important joint coming is acromioclavicular joint. Now, these are the areas where we will be focusing on the imaging to a maximum. And as I said again, the anatomy, when it goes to the MR, becomes more and more complex. So, The simpler way of interpreting it is by always going with the X-rays first. Now, why I am saying this, that most of the times in practice, patients are referred to us for ultrasound or MR or CT and MR, whatever it is. We first look into the X-rays, then only proceed. That's a dictum anywhere as far as a radiologist is concerned. Now, regarding the movements as far as anatomy is concerned, the basic movements, 6 movements, all you know. And of that, the muscles defined also has to be important. Why? Basically because when you focus on the imaging, any muscles which we need to focus, retrospectively we will be focusing it on MR. Especially in case of MR, when you look at the muscles, we have to have, we either take an in-to-out approach or an out-to-in approach. What I am saying is, if you want to diagnose something, you can go from the inside structures to the outside structures, or from the outside to in. So most of times we take an outside to in approach. That means that from the muscles into the tendinous structures, into the joint capsule and the cartilaginous structures, and then into the bone. Like that is the most easiest way to do it and to pick up the lesions. So we'll always focus, look at the muscles first, and these are the movements associated muscles, which you will keep it in mind. Whether there's any atrophy of the muscles is there, whether there's any fatty replacement is there, we all look into these things first. Then we go inside. Now why plain X-rays? Well, basically, I'm putting in a very simple way. Basically, because of the reproducibility, because of the cost effectiveness, and because of the accessibility. Everywhere you can have an X-ray accessible. Any diagnostic center. Second thing is that reproducibility. You can keep it on, for the patient can keep it, you can go with the patient to the clinician and reproduce. Cost effectiveness, of course, is there. Now, basically, an AP projection is enough. An AP projection is enough to get into a first line of approach. Well, sometimes, rarely we take an infrasuperior. Nowadays, we don't take that because of the CT reconstructions are coming. We don't take much of an infrasuperior view. The basic drawback is that as an ultrasound or a CT or an MR, the information we get, of course, is limited. But then the approach always starts with an X-ray. That's very important. Now, this is shoulder AP view. That's what the primary take. You can see the I think the point, can you help me with the point? It should be here, right? Okay. Now, we can know the normal anatomy, but this areas. This area where most important will be this joint and this area, this joint. Now, what other structures you look for are the soft tissues around the joint and also the calcifications. Now, these are things which are first primarily we look into it. Now, rarely we take, nowadays we don't take this, but some people take the infrasuperior view. Now, I focused on the traumas. And these are the basic traumatic lesions we look into. Basically, the dislocations and the fractures. These are areas where we look into moving very fast. Now, there is an anterior dislocation of shoulder. Now, if you look at the posterior dislocation of the shoulder, the difference between anterior and posterior is very clear. And from a look itself, we can diagnose that. The inferior and anterior dislocation of the head, while in the case of the posterior and superior dislocation of the head in the posterior. Now, there's that labile sign in posterior dislocation. Sometimes you can have an infra-superior view to show the inferior dislocation also. Now, coming to the fractures, commonest site of fractures is surgical neck of femur. You have a one-part or a two-part type of fracture. Now, these are very important as far as the orthopedic angle is concerned. For that, we have to mention the type of fracture, the displacement of the fracture structures. They are all, what happens is that you have to have an idea given regarding the multiplanar structures. For example, if you have a fracture of the neck of femur, a fracture fragment is demonstrated in a plain X-ray, what is the advantage of CT, people may ask you. Now the importance is that in a multiplanar imaging of the axial, coronal and sagittal, you can see the bony structures better and displace bony fragments, which we give a volume render technique and demonstrate them for the orthopedicians. Now, as far as that's the plain X-rays, and I would say the plain X-rays are still the most important. I've gone very fast. I know that I've gone very fast, but they are the most still very important for us. Okay, going to shoulder ultrasound. Shoulder ultrasound is something very common nowadays. Now, as you know, there's no radiation exposures. The patient compliance is good for this. Why patient compliance is good? You can refer the patient, or you can go, a patient can be, it's not like positioning an X-rays or positioning for a CT. It's very easy, comfortable for the patient. Then sometimes you can have a mobile moving type of the resting and moving states we can do. Most important thing is the fluids. Now, as far as ultrasound is concerned, they can easily pick up the fluid. Now that's a lead point. Wherever you see the normal anatomic structure, you see a fluid, you go via that to the structures there, especially tendon structures, and identify the pathologies. Now, portability and use guidance in anatomy. Now, coming to the guidance, most of you people do the guidance with this ultrasound. Handy, you can do the therapeutic guidance, so whatever guidance you do, you can give the ultrasounds. And then the most important thing here becomes the operator dependability. Now the thing is that as far as ultrasound is concerned, the structure identification is always operator dependent and based on the skills of the person doing it. Identifying the pathology also is like that. I'll come to just the procedure technique. Now, that's a basic technique of ultrasound being performed. And look, I'm more interested in the positions of the probe. And you can see that, what you see actually is the long head of biceps. First, you say identify the bicipital groove, long head of biceps tendon. I tell you what are four basic structures here. First, you identify the biceps tendon. Then you go to subscapularis tendon. And then you go back to the RC tendons. And this is in the four positions which you are doing. And you can see the probe here placed. It's a very simple procedure, routinely done in OP or an IP setup. And that's a position 2 is going for subscapularis, move medially. And go more superiorly towards the acromoclavicular joint, one of the important joints where you have a lot of pathologies. You have to identify the joint, whether there's any thickening there, whether there's any fluid there, or in bursal fluid, or in the joint space fluid. And then coming to the most important part, look at the position of the hand. It's going back for the supraspinatus, so insertion. And supraspinatus insertion, of course, that is the area where, insertion 2 centimeters where about 80% of tears are always occurring. And that you can identify subacromial, subdeltoid area. You can see that there's a dark area coming here. The dark area coming, that's the fluid there. And you can move, as I said, mobility also can be assessed. You can move the tendon and see it move. especially in the case of tears. Then going to position 4, posteriorly, that comes with the infraspinatus and tetraspinal. So basically there are 4 positions. You can identify the biceps tendon, the subscapularis, the RC tendons, and then of course the acromioclavicular joint, and then the joint capsule. Look at the joint capsule and the humeral head appearance. Now, most important thing here comes is basically we don't get patients like this. A well-formed deltoid, well-formed all the pectoralis muscles. Most of the patients we not get with a good windows. And the obliquity of the props also very important to assess this tears and all. Now, you can identify the tears, very closely watch. As I said, you can also identify the bursal fluids, which I'll come into later. Now, this is the simple ultrasound technique. You may finish within 10 minutes. But the most important thing is that if you can get a good window, everything is easy. But you have to get to a good window, you take a little bit of skill enough to identify the structures properly. Now, almost all tendons can be easily identified here. The muscles can be identified here. And only things which are left will be the cartilaginous structures and ligaments. Sometimes by the side, you can identify ligament injuries also. Now, that was said regarding the CT imaging. Here, CT has a limited scope as far as shoulder is concerned, because basically the bony detail is more pronounced, of course, but we don't need much of bony detail here. We are more interested with the soft tissue anatomy and the soft tissue pathologies around. Second thing is that sometimes CT may help in identifying loose bodies and subchondral fractures and calcifications. Of course, that's one area where CT can help, because in X-rays, sometimes faint calcifications may not be identified, but you can identify that in CT more clearly. I'll show you a picture. If you wish, calcific tendinitis is a common condition, supraspinatus or infraspinatus. Here you can see that X-ray, there's a host calcification there. But the importance in CT is that you can identify that calcification in infraspinatus tendon, towards the infraspinatus tendon insertion. And you can take a bone window or a coronal reformatting. You can see that's an axil, and this is a coronal reformatting. The bone window, that lesion is outside the humeral contour. Now, these are very important as far as arthritic lesions are concerned. Sometimes you can have subchondral lesions in the bone. Sometimes you can have periarticular erosions and all. Sometimes you can have loose bodies. These things are all, when a X-ray is taken, you may create confusion, but in CT you can identify the anatomical compartment clearly. So that's just an advantage of CT. Now coming to the most extensive imaging, MRI, which everybody is relying on as far as shoulder is concerned. Important of the MRI is that it's better soft tissue contrast. What you identify is the soft tissue structures, the muscles, the tendons, and then the ligaments, and then the cartilage around the joints, and of course the bones. Now, multiplanar imaging. As I said, the joint is in oblique plane. So even in multiplanar imaging, you may have to take an oblique sections, and that is set in the shoulder imaging patterns in MRI. Then what are the basic sequences? I'll put it in a very simple way. What are the basic sequences in MR? In MR, we take T1 and T2 coronal, and PDF is the most important. That's a proton density fat suppressed. Then in some cases, we'll take a stir images also if there are any fat lesions around the joints. Now, the basic sequence of T1 and T2 coronal, it can be taken, if you want, you can take axial coronals also, but basically PDF is in all planes, and the T1 and T2 coronal is suffice to pick up all the lesions. Now, what to look for in MR? In MR, you have to look at the bone first, acromioclavicular joint, as I said, then the coracoid large bursae, rotator cuff, RC tendon, biceps tendon, and subcapularis tendon. Then the glenohumeral articulation, labrum, synovial, joint space, the most toughest area. Rest everything, first four things are very easy to be conquering your pathologies. This glenohumeral articulation, labrum, synovial, joint space. Why? Basically because the structures there, the lesions there are slightly more complex, and therefore you need a better image, and also sometimes MRI may not be enough. I mean, you may have to go for MR orthogram. I will move very fast. These are the common pathologies you can see in MRI, and if you look at the basic PD sequences, this is the, I'll take just 5 more minutes, coronal, axial, and sagittal. These are the anatomical coronal, axial, and sagittal. Now the importance here is that the contrast. In a PDFS, the tendons, the cartilaginous structures, everything are black. So whatever lesions become white, it can be easily picked up. That's why the importance of a PDFS. And then this is a coronal image of a T1. Bony anatomy is better seen. You can see that the cortex and also the marrow is the bright bright marrow which contains the fat. Now in fats are all hyper and T1. So a bony detail is better seen, while in case of a T2, here the marrow is better seen. The marrow in edema and all, the marrow becomes more bright. Here bone marrow becomes, all the edema in the bone becomes better seen in the T2. So purpose of a PDFS T1, T2 differ in picking up the lesions. This is a normal RC, the most important structure to identify in MR. And you can see the rotator cuff with the supraspinatus insertion there. And this, look at the complex tear of
please use the pointer.
You have identified a normal.
Dr. Manoj,
Now,
please use
if
the
you look at
pointer.
that, you can see that there is a total cutoff of the tendon there. Total cutoff of the tendon there, and the fluid coming in between. Now, here the tendon is there, but there is a total cutoff. That's a complete tear. While sometimes the tendon may get refracted and there's an empty space, only fluid there, that's called a retraction of the tendon, which you see, we have seen in reports, there will be a tendon retracted. This is not retracted. There is a partial tear. You can see that the fluid going in, the tendon is not completely cut off by the hyperintense lesions. It's a partial tear. So these are the ways in which, in a PDFS, we identify the tears. Now, bursae, anatomically, bursae are various bursae. You are seeing the bursae. You know, the most important bursae will be subacromial, subcoracoid. And can I take 2 more minutes with the permission of the chair? Okay, fine. Now, regarding the bursae, the bursal fluid, as I said, the bursal fluid is very easy to identify in ultrasound and also in MRI. Now, if you look at this is more important in case of degenerative lesions. Anywhere degenerative lesions, the bursal fluids you will have to identify. Then you identify the normal bursae and you can trace the bursae. And most important will be subacromial and subcoracoid. Now coming into various conditions like adhesive capsulitis, I'll show you impingements. These are more common. Impingements have an X-ray diagnosis of impingement with you can even measure with the distance between the humerus and the acromion. But what you see in MR actually is the secondary changes in impingement. That means the tendinosis plus the fluids. Now here you can see that there's a tendinosis of the infraspinatus, and you can see a partial thickness tear also. Sometimes in impingements you get the tears also will be associated. And with tears we can have developed tendinosis. Tendinosis means it's a swollen type of tendon. A reaction to the what you call compression or whatever force happening in the tendon on a chronic process is tendinosis. Can be demonstrated. Then that's a subcoracoid. In case of subcoracoid, the most important thing is the fluid. You can see there, the hyperintense area. And why I'm saying this, when you see a fluid anywhere, adjacent bursae, look for the adjacent tendons. You can see the lesions, slowly you have to pick it up, either in MR or in ultrasound. Instability, the most common area where you look. And in instability, of course, the lesions, basically lesions look for is a Hill-Sachs lesion and the Vanguard lesion. Very clearly seen in MR. This is a typical Hill-Sachs lesion, is a hypointensity area there. And in ultrasound, you can see the contour, the posterolateral aspect of the humeral head. If you look at there, there's a contour, there's a normal humeral head, and you can see contour different. Very closely you have to look. In a bony Vanguard, you can see that X-ray itself is a glenoid, lower part of the glenoid aspect. You can see a defect-like thing. You can see that in the coronal reconstruction of CT. And then you can see that in MR, you can see that fluid sensitive MR, you can demonstrate that abnormality at the level of the glenoid, and most important than anatomy. This you should always keep in mind. The glenoid rhabrum and bony Vanguard lesion. If you can make this thing by heart, then the cartilaginous, that's the most complex etiology is coming, will be very easily identified. I'll go to that. So there's a bony Vanguard is there. Along with that, there's a cartilaginous problem also. Sometimes you may not have a bony, only a cartilaginous defect is there. Now look here, the same MR patient with a Hill-Sachs also, you can see the Hill-Sachs, they may be associated. You can see the lesion here, along with that the lesion here. It's an axial image. Now you have to be well versed with the axial, coronal and SAC. Whenever people send you films, I think you can just you can place the films and you can look into it. You can put the coronals, axials. Sometimes they may be separately given, sometimes they've been, sometimes...
Please conclude, Dr. Manoj.
The axial will be all given in one film. You have to look very carefully to identify the axial, coronal and shoulder. Now the labral pathology, that is the most, you're going in finally to the labrum. And the labral pathologies, you can identify in the, which section? Coronal, axial or SAC? SAC. That's the appearance of the labrum coming in the SAC. So you'll have to identify that various type of labral pathologies, extensive type of labral pathologies. Here, MRI stops and the next investigation starts. That's the MR arthrogram. Basically because so much of complex things, it cannot be demonstrated in a simple, even 1.5 Tesla or 3 Tesla MRI. All the lesions you'll have to go for MR arthrogram.
Dr. Manoj,
sometimes abduction, external rotation, MRI may help.
Dr. Manoj, please conclude.
Thank you, ma'am. I'm sorry that it's all MRI is the area where you have to be more extensive, but I couldn't complete it because 20 minutes I was given to show shoulder imaging of all modalities. And my thinking was to give a roadmap on all the modalities. Of course, MRI is the edge in shoulder imaging, but still all modalities you have to keep in mind, especially ultrasound and X-rays, and then you have to focus on the MRI. All patients you cannot do an MRI, but those needed you have to do that. The take-home message is that you can need MRI with soft tissue detailing delineates the pathologist further for proper diagnosis, and most important, URI, US and MRI for prognosis and intervention. Now we have done a lot of intervention with ultrasound and MRI prognosis wise. You do it in whatever, you're treating a patient in prognosis wise. These are things, as far as the imaging is concerned, MRI is the gold standard for detecting all pathologies. But you have to have a methodical approach with X-rays, ultrasound and MRI, and if you need a CT. Thank you.
Thank you, Dr. Manoj.